instead of at a research conference. So thank you all for allowing us to do that today. So we are going to be talking about the TEAMS trial, a shorthand for testing the effectiveness of an organizational implementation strategy for 2 evidence-based autism interventions in schools and mental health. You can see why we call it TEAMS instead. As a little bit of context, we started this trial because, as many of you know, we have a large set of evidence-based practices that are pretty well established for autism, strong research support for supporting kids' mental health, academic, social skills, especially for young autistic children. And we have compendiums of those and spent a lot of time and money studying those, including work Lauren and I have done. But despite having all those practices, it is still very challenging and very rare that they are used in community practices for a variety of reasons. And so we've really wanted to move our focus from developing interventions to how we can help them be useful to human people in the community. And so we have turned to implementation science to do that. And looking at, since we have effective practices, we want to get to socially significant outcomes for kids. We've been looking at how we can make implementation more effective with a focus on the context of the providers and how they feel about the processes and how they're using them, as well as the organizational context that might or might not support the use of these practices. So that's where our focus is today in terms of what we want to talk about, is how we're going to use those implementation strategies to help. And so we know, and I'm sure all of you know, that autistic children are served in multiple systems, especially in our state. Mental health and education serve the majority of autistic children, and those are the 2 areas or systems that we're going to focus on today. So now we're going to go back maybe a decade and talk about how we got here. And so Lauren and I were both working in different systems, thinking about how we could help adapt or develop evidence-based practices for use in the community. So our team was working on classroom pivotal response teaching, which was an adaptation of a naturalistic developmental behavioral intervention. And we were working on that in public schools. And Lauren's team was working on AIM High, an individualized mental health intervention in publicly funded mental health. And so at the same time, for PRT, we were adapting collaboratively with teachers and education leaders, this intervention that teachers were using, but it wasn't working great in the classroom. So we adapted it, and then we conducted a trial that showed that teachers improved their use of the strategies, and that led to better child outcomes. At about the same time, Lauren's team was working with mental health providers, leaders, and caregivers to develop an intervention based on multiple evidence-based practices so that mental health providers could support autistic children who were receiving mental health care. And their trial showed that the therapists were learning the intervention, and that also led to better child outcomes. So we started looking across both studies to think about what we could do for the next step of improvement. And what we found that fidelity, or the provider use of the strategies, how easy or how well they were able to use all the pieces of those interventions, was really variable. Even though they were learning it and it was much better than not learning it, still there were challenges. And this is important because the level of fidelity that folks reached was really associated in both studies with how well the kids were doing. So we wanted to improve fidelity so that child outcomes could be better. So this is when we started to merge our studies to try to figure out how we could develop some implementation strategies that would help support that primary outcome. So effective use of the interventions, which we were measuring by whether people completed the training and how well they were using the strategies in their practice. And so the 2 things that we found to be most important across both those studies was how engaged the leaders were, how much support the leaders in either the clinic or the school district were at helping the providers get set up to be successful, And then also the provider attitudes and motivation related to training, sort of like how into it were they, right? How engaged were they in the training? And so those are the two areas we started looking at to test strategies that would improve those, to then improve the provider support for using the interventions across those two different services. So that's where we came up with teams, and this is our partnerships across multiple universities. And as you can see, this is our starting team for this project, and we have had a lot of folks work on this. And so this study was actually 2 linked grants, one for AIM High and one for CPRT, but we combined them across the state. 3 primary sites were in Sacramento, San Diego, and Los Angeles, but we then expanded to do training across the state. Lauren leads the AIM High project, and I lead the CPRT project, and Anna Lau is our site director and the Los Angeles site. So I'm going to try to describe the sort of logic model for this study. What we really wanted to look at was the impact of pairing AIM High and CPRT with 2 different implementation strategies, or these teams modules. So the first is a leadership strategy that worked with leaders to provide support. And the second was an provider level strategy to help build that motivation. So I'm going to talk about both of those, but the main aim you can see from this figure is to take the autism intervention, link it with the implementation strategy, and see how that affected outcomes, both for the providers and their use of the strategies, but also did that make a difference for kids? So that's the kind of premise of the study. And if you all have questions, just please put them in the chat or shout out as I go. So our leadership intervention, I'm just going to talk a little bit about this. We called it the Teams Leadership Institute, and it was adapted from an intervention developed by Greg Ahrens and his colleagues called the Leadership and Organizational Change for Implementation Strategy, or LOCI. And we adapted that to be a little more targeted towards implementation for use in children's mental health and education. And so the key components that we did was first a 360 data collection, which means we collected information from executive leaders, mid-level leaders, and providers about how the organization was supporting implementation of evidence-based practice generally, what kind of supports were they already providing, and what kind of support were individual leaders providing to their teams if they were trying to institute an innovation or a change. And we used the data from those assessments in a workshop. We did a half-day workshop to develop goals around implementation. We call the organizational implementation climate, and implementation leadership. And so we set up some goals in that workshop. And then we did about 6 months of ongoing coaching, and 1 to 2 times a month, where we reviewed the goals and made adaptations as needed to support the leaders in supporting their providers. And then we ended with a sustainment planning session and graduation toward the end, so things could keep going beyond the length of the study. And so just to give a little bit more kind of context or examples, here's some example goals that folks chose in these different interventions. So for implementation climate, or that organizational level, oftentimes people pick goals related to recognition. So recognizing providers' use of the evidence-based practice in supervision, or emails to teachers saying, great job using CPRT. And so that they knew that people were recognizing that they were doing this hard thing. Also, providing educational support seems very important, right? So do people have the materials they need to do this new intervention? And do they have the time they need to do the training, the practice, and the coaching? And then the most common goals in implementation leadership that leaders were setting up for themselves were things around being proactive. So thinking ahead about how they can support people before problems come up, or catching things as they go. So checking in, for example, about obstacles, supporting therapists in addressing clinical productivity so they had time to do the intervention. And then also being knowledgeable about the intervention. And they did this by attending workshops or reading handouts about the intervention so that when providers had questions, they had a little bit more understanding about what those providers were trying to do. So those are just some examples of the kinds of goals that we worked on and that they reviewed with their coach each time to either have completed it or continue with it. And then the team's individualized provider strategies for training or tips were based on strategies of motivational interviewing. Wasn't the full motivational interviewing package, but we did use a pre-training call where the coach that was training in the evidence-based practice would talk with the provider about what to expect, identify any challenges or concerns the provider had, and think of some strategies to address them. Each session had some proactive planning and feedback where there was a little survey the provider would do, and if there were challenges, that would be addressed. They got some motivational reminders via email each month to think about how they could kind of boost their use of the strategies. And then if they were having challenges meeting the requirements or coming to sessions, we had some rescue strategies. And now I'm going to let Lauren talk about the study procedures.
Thanks, Auburn. So we conducted a randomized controlled trial where we really started with recruiting programs, so mental health programs and school districts. And unlike your traditional randomized controlled trial, we randomized programs to different implementation conditions. So once we enrolled the programs, we randomized them to different implementation conditions, which I'll tell you about in a moment. Then from within those enrolled programs, we recruited providers. So in school districts, we recruited primarily teachers. In mental health programs, we recruited therapists who are providing psychotherapy. And then from within those providers, caseloads or classrooms, we recruited children and families from those participating providers. Once we conducted recruitment, we started the Teams Leadership Institute for a subset of programs who were randomized to that condition, that implementation condition. And then for all programs, we conducted the AIM High in mental health and CPRT in schools for approximately 6 months. So the training for AIM High and CPRT included initial workshop, introductory workshops, and then ongoing coaching or consultation for approximately 6 months. Then we collected data at the beginning before we started our training and implementation strategies at baseline, and then after 6 months. Next slide on me. So we randomized our programs in school districts to different implementation conditions. So some programs were randomized to our gold standard CPRT or AIM High training, and some were randomized to receive that training with the Teams Leadership Intervention. Some had an enhanced training, which was the motivationally enhanced training or TIPS, and some got both. So they were randomized to 4 different implementation conditions. Next slide. And so what we were really interested is what are the effects of the Teams Leadership Institute and the TIPS motivational enhancement strategy on key outcomes. In this implementation study, our primary outcome was provider fidelity. So that was really the use of strategies as the providers were trained. So when teachers, so in CPRT, study was teachers' delivery of classroom pivotal response teaching. In the AIM High study, this was mental health therapist delivery of AIM High. And we also, our ultimate goal is to maximize the benefit of our implementation to children. And so we also looked at child outcomes. In the CPRT study, the child outcomes, and these are parent-reported child outcomes. The pervasive developmental disorders behavior inventory was used for CPRT, and the IBERG child behavior inventory was used for AIM High. I should say for both of these measures, the raters were really naive to the implementation conditions. So in the case of provider fidelity, we had trained raters who rated video recordings of sessions with providers. They were naive to the implementation condition. And then the parents who completed the child outcome inventories were also unaware of the implementation condition. Next slide. And so we had a lot of participants in this study. So so we had close to 200 therapists in the AIM High study and close to 200 teachers in the CPRT study, and similarly almost 200 families in both studies. And we combined the data from both of these studies from the beginning, the outset of the study. These were linked studies, and data are combined. Next slide, thank you. So just as far as who are our providers that participated in this study, our providers generally are representative of the mental health workforce in California, in the AIM High study, and the teacher workforce in California. You'll see that there are some differences in studies, which we would expect in who the providers are. There are mental health providers, of about equal distribution of Latino and non-Hispanic white participants. In the teachers, there were primarily a majority non-Hispanic white teachers. In the mental health study, almost 40% were bilingual in Spanish, and much less so, less than 10% teachers that participated. They didn't really differ by study in age. We had both primarily female participants in both studies. Next slide. And so in both studies, master's level of education was most common, but this is especially the case in AIM High, which reflects often the mental health workforce in California. And the studies differed by discipline as expected. So in the AIM High study, most of the participants were MFTs, or marital and family therapists, or social workers. We did have some clinical psychology folks in there. And these are our primary, these are the most common discipline. There's a variety of other disciplines as well. CPRT, a majority of the providers were special educators, some general education, speech and language pathologists. What we found in AIM High is that very few of the providers indicated that they specialized in autism. And this is consistent with our prior data on the mental health course in California. So although folks are seeing these children, they don't report specializing in this population. In CPRT, we do see a majority of those special educators indicating that they specialize in autism. The average years practice in AIM High was about 5 years and about 7 in CPRT. As far as the children differed in age, and that really relates to the age range of our interventions. The AIM High intervention was geared for 5 to 13, whereas CPRT started a little bit younger. We see a significantly more diversity in the AIM High sample, but relatively diverse sample in both studies. Next slide. And so our question is, did the implementation condition, our first question is, did the implementation conditions affect provider delivery of that evidence-based intervention, either CPRT or AIM High? And so just a little bit more detail about provider fidelity. So we had different observational fidelity measures that we used in each study. And they were established coding systems, but these are some coders in both systems rated on a Likert scale and the aim high, to what extent the strategies were being used, the aim high strategies were being used. And CPRT is the extent to which the provider was using the strategies appropriately. And there's some examples of the items in on the right side of this slide. So we combined these data. So we transformed these scores so that they were all on the same scale for our analyses, because they were slightly different scales. Next slide. So what did we find? I should start by saying what's not on the slide is we did not find a significant effect of TIPS. So as a reminder, TIPS is the condition in which we really targeted motivation for the provider in training. We did not find any significant. What we found was that TLI, the team's leadership intervention, is that we saw significantly higher fidelity in the TLI condition than those providers who were in the non-TLI condition. Next slide. And so then we also were interested in, did the implementation condition affect child outcomes? As a reminder, the research team were not involved in delivering care to children. We were focused on how do we best train providers and support providers in delivering care. So similarly, we did not see an effect of TIPS on our two outcomes. So again, we used the ECBI for aim high, and we used the PDDBI autism composite for CPRT. I should highlight that reductions in scores means improvement, and we looked at outcomes over 6 months. Next slide. So what do we find? So again, no impact of, or no significant impact of the TIPS condition, but we did see the orange line here is the TLI condition, Teams Leadership Institute, and we saw greater reduction in children who were receiving care in organizations and school districts in which their leaders were part of this intervention or this implementation strategy. There were some improvements in the non-TLI condition as well, but there was greater improvement in the leadership condition. Next slide. So we're really interested in why did TLI work? Why did the teams implement, or the team's leadership institute work to improve implementation? Next slide. And so we did some semi-structured interviews with leaders who, after they participated in the Teams Leadership Institute, actually in our first year of doing TLI. And two main themes really came forward of what they highlighted as what was helpful, what the leaders highlighted what was helpful about Teams leadership. The first theme was really that the ongoing coaching really helped with structure and accountability. And so I think this quote by one of the leaders is really illustrates that knowing that I was going to be following up with a coach on progress and goals helped me stay on track. So that was really important. And I appreciate in this quote that's in the blue box that the leader highlighted that without that accountability, it would have taken twice as long to achieve the same goals. And so that accountability really helped to accelerate the implementation support. The other piece, and we haven't really highlighted this too much, but the Teams Leadership Institute really was included a team of leaders. In most cases, a team of leaders from each mental health program or school district. And so teams of leaders really participated in the workshop where the initial goals were set, and then also the ongoing coaching. So this having a group was really common. And so leaders highlighted that the alignment of leaders within a context was really helpful in the context of competing demand. There's always fires to put out, there's always competing demands. And I think that some of these quotes really highlighted that having time devoted to together planning for the implementation was really helpful. There's comments about being on the same team, bringing the management team together and having them all on the same page, and then maintaining leader motivation and focus on strategic initiatives, again, against competing demands. So this was some of the leaders' perspectives on how TLI was helpful. Next slide. We also collected quantitative data. These are surveys that we conducted with leaders at 6 months. So kind of at the end of Teams Leadership Institute, at the end of in-high CPRT training. And what we asked leaders to do is rate the extent to which they reported using strategies to support that active implementation. So, and what we found was that leaders who were in TLI condition and those who were not, they reported using lots of different implementation support strategies. But those leaders in the TLI indicated that they used these strategies more extensively. So the orange bars are those leader ratings from the TLI leaders. The blue are those that were not in TLI. And so just in case these are too small on the slides, some of the examples were, so EBI is the evidence-based intervention. So that really just refers to in-high or CPRT. And so the first one is that EBI was included in individual meetings with managers or supervisors. Another one was designating time for training and practice of that evidence-based intervention, rewarding evidence-based practice use, recognizing the efforts of the providers. And then the last one on the slide, and these are just examples, is that EBI was linked to other organizational priorities and constructs. So again, the leaders report using lots of strategies, but use them more or report using them more when they were part of TLI. So we were, and I should say, this is just the start of us unpacking why did TLI work and why didn't TIPS work? And so some of our hypotheses of why there was no significant effect of TIPS. First of all, based on some of our data, providers came in with pretty positive attitudes about the intervention. And so we should remind folks that this is a research study where participation in the training, either in higher CPRT, was voluntary. So in research, participation is voluntary. So leaders didn't mandate or require that folks participate. So there was some self-selection to those who decided to participate in the 6 months of training. So that's one. So that's one potential explanation, is that the providers, the teachers and the mental health providers were already coming in with positive attitude. We also think that, so we embedded some motivational interviewing strategies in our training approach for therapists and teachers. We think that the dosage may have been low due to our group training and coaching format. So our workshop was in a group. Most of our coaching happened in a group format. So we think that some of that individual motivational strategies, the dosage was low. And then we should highlight that our gold standard training models that didn't have the TIPS enhancements they already did incorporate best practices in training and coaching strategies. And so we think that potentially the two conditions of training weren't that different. So these are some of our early hypotheses for why there wasn't an effective tips. Next slide. Alvin, I'll turn it back to you.
Thank you. Jill asked about COVID, and I realized we did not say anything about it. It did happen in year 3 that the world shut down in March of our 3rd year of training, and in schools and clinics, that was really significant. And so good question. So in all of our analyses, we did take that into account by year and did not see a difference, which is, I think, why we stopped talking about it so much. I think we could do a whole presentation on what we did then, but the specific question was, how did we do the video observations? And so for the schools and mental health clinics that continued with the study, and most of them did, many of them shifted to virtual, especially for that last part of 2020 school year, shifted to virtual either classes or virtual therapy. And so we recorded their Zoom meetings and did the fidelity that way. And I think it might have been, maybe Lauren, you could correct me if I'm wrong, a little more challenging for schools. It's hard to deliver a reinforcer, for example, via Zoom, but teachers can do it. They were pretty amazing. And so that's how we did that. And then for some of the final cohort, they continued to be virtual for the entire rest of the study, and others went back to in-person. And so we just did the video recording wherever they were. So our take-home points, leadership support is important for effective provider training. I think that is really key in both schools and mental health clinics. And one question was sort of what was the level of leader? And it varied quite a bit, but mostly mid-level leaders. Some of them might have been supervising the providers, but some of them not. And they did not get any of our data for part of their supervision. So that was all separate. In schools, we often had a behavior specialist and sometimes the special education director on our leadership team. Lauren, are there particular people for the clinics?
Yeah, and the clinics, excuse me, they varied by clinic, but program managers, so those who had administrative responsibilities over the clinic. So program managers, to some extent there was higher level when there were multiple clinics within a agency, then kind of a higher level, closer to executive leader was in part of the TLI team. Some leaders brought in some lead clinical supervisors, others did not, but at minimum, the program manager.
And at schools, it was really primarily district level. We had principals who participated in different ways, but not on that leadership team usually. So this tells us that teachers and mental health therapists need resources, recognition, coaching, and more time to learn and deliver interventions well. And they can't have that without leaders. And, you know, it's funny because in a leadership role now, I think about my job as mostly sending emails. And so I was super excited, to think about as a leader that active leadership and engagement in the intervention is actually good for kids. Those child outcomes, I think, hopefully are really exciting for leaders who know that their actions are directly affecting how well kids are doing from their parents' perspective. So I thought that was pretty amazing. I see there's some questions, so let me just finish up these last couple slides and then we'll have time for questions. So our next steps are thinking about more deeply about which implementation supports were most effective so we can streamline our training and think about which might work better in which context. We also want to look more closely at this team approach to TLI because it was something that really happened in the context of our settings where they were saying we need these teams. So we want to think about who should be on those teams and how can those roles be optimized. And then because this leadership intervention was pretty successful, we want to think about how we can adapt it for implementing other interventions, not just AIM High and CPRT, but how it can be effective in that way. And so in order to do that, I'm going to shamelessly plug 2 new studies that we have in case anyone has interest in participating. And then I see some really great questions. So the first study we are pre-enrolling right now. This is part of the great new Alacrity Center at UCSD, where we're looking at how we can improve TLI teams, how the teams work together to support distance training. Because when we did the distance training, we learned that there were some things that were unique about it that might need sort of different team configurations or different strategies. And so we're going to spend the fall collaborating with schools and clinics to refine that process. So if you'd like to help us with that, please do. You see the email up there on the screen, and I think someone's going to put the link in the chat for these. And then we're going to do distance, aim high, and CPRT training along with that team intervention. And so for folks who enroll in this, the leadership teams will all get the TLI intervention, and the providers will all get the evidence-based practice intervention using distance technology. And because we're doing it at a distance, we can do it across the country, not limited to California. And then we have a study that's enrolling right this minute where we are testing a team's evidence-based practice leadership institute, where we're supporting teams in identifying evidence-based practices that will work for them through a series of steps and workshops with a coach to look at priorities and needs, assess fit, use the registries that we have to choose an intervention, and then monitor and sustain it. And so for this, all the leaders receive the Leadership Institute sometime in the next 3 years. And providers are really just participating by doing a survey at the beginning and the end of each time period. This will be generalizable to multiple EBPs. So we're hopeful that this will be something leaders can use across autism evidence-based practices, but maybe others as well. And it's open to programs and districts in California. So you can email us for more information about that, or go into the chat. There should be a link where you can fill out an interest form. And then again, just a giant thank you to all our participants. I see some teachers that we worked with here, some clinicians, some leaders. So excited that you are here to hear what happened. And of course, the families and our partners in mental health and education, and our staff and our coaches who have been incredible, and our funder, NIMH. So I'm going to stop sharing, and then maybe we can look through the chat, Lauren, and see questions. I see that actually, Josh, you have your hand up.
Thanks, Autumn. What a beautiful study, you guys. Oh my goodness, it must have been so hard. I was interested in